I got sort of strong-armed, not really, but encouraged by Dr. Schiff and Dr. Bennett to, Dr. Weissen is a nice guy. He didn't care whether I talk about vignettes. I am not a great advocate of discussing treatment or treatment, presentations of case presentations for a variety of reasons, some of which I think I will try to address here. I'm just going to turn my phone off. Thank you. But I decided to let Dr. Schiff and Dr. Bennett present more, anecdotally the nature and how treatment works, or what orgonomy looks like in practice. And I decided to really address the issue of how and what orgone practice, orgone treatment clinically is, and use vignettes and some ideas of what the problems of understanding any kind of therapeutic model. Dr. Weiss and I at lunch were talking about the pros and cons of various ways of working. So to quickly just tie into the last comments on transference, we were talking about different ways in which, in fact, we agreed that Reich really didn't reject transference. He just found it to be difficult and creating many problems in the nature of work. It got in the way. But in the final analysis, one of the last things that he said in developing the various physical devices, like the accumulator, the shooter particularly, the doorbuster, was that the hope was that he could create a situation where you could do treatment and restructure an organisms without dealing with the transference. And the last thing he said to the doctors that he was working with when he was demonstrating the use of the doorbuster. For those of you who don't know what a doorbuster is, it's an accumulator device that essentially, it's hard because Reich himself wasn't sure exactly what it was, as it turns out. It does move energy and stirs up energy, and it either in certain ways appears to draw energy, in other ways it appears to increase energetic charge in the organism, or move energy, or stir it up in that kind of stirring motion. That said, his hope was that by developing these devices, he would be able to just interact with the patients without dealing with the transference. And his final comment was, it doesn't work. He said, because when you stir things up, you stir up emotional, interpersonal relationships. Therefore, you always come back to the fact that you got to deal with who we all are in the moment, face to face. So, in keeping with that, where I felt I would start was with an anecdote. Start with a few things about what I know from personal communication with Dr. Sovey and Dr. Handelman, who were and Dr. Rothenberg, who had less contact with Reich, and Dr. Morton Herskovitz, who all had contact and trained to some degree with Reich, although Dr. Rothenberg didn't actually train with Reich. He worked with Reich as a lab assistant, but had conversations with him. The first thing, and where I wanted to start out, was Reich would always tell patients, and I tell patients, and they often ask me why, and so I figured I'll answer it. The question is, I tell patients, and Reich told patients, you're not to talk about your therapy with anybody else other than me, the therapist. Right? And by that he didn't mean you couldn't say you were in orgonomy. It didn't mean you couldn't say that you thought orgonomy was interesting or what the basic principles or the nature of the work. But he really meant that you're not to talk about the specifics of what's coming up in therapy, how therapy works, what your therapy is. And that was to be something that was exclusive to the session between you and the therapist. And patients often respond to that with the feeling of, well, first of all, anecdotally, when Reich said this, everybody evidently pretty much lived by it. And so they were too afraid. There's a sense of probably like almost a Woody Allen movie where if they started to talk, Reich would step into the room and say, "You're talking about it, stop." But the fear of the master's kind of imposition probably says something transferentially and counter-transferentially. But specifically what Reich was really addressing, so when patients ask me why, some patients see it pretty clearly and pretty obviously, but when asked why, I think the real answer and what Reich was clearly getting at brings us back to the issue of energy. And what Reich was saying is, and what I'm saying is that that it basically, that when you begin to talk about what's going on in your therapy, in your sessions, in the work that you're individually doing, it dissipates and it directs and it deflects the buildup of energy. It makes and it taps off energy and it fragments and in a variety of ways creates a more chaotic situation and doesn't allow for the interpersonal relationship between the two organisms, the therapist and the patient, to build. It also doesn't allow for the energy in the patient to build so that the therapist can actively begin to, with the use of various techniques, right, help that organism begin to tolerate increased, and as Dr. Schiff was talking about in his preliminary remarks, increased pulsation in the organism, and subsequently use that energy to begin to work as you work through the various segments, to bring that energy to bear on the areas that need to be worked on. So one of the key things that I think Reich is addressing is if you have a patient who has a block, say in their chest, and they have traditionally or characteristically avoided that by talking a lot, okay, and particularly by constantly telling people what's going on with them, what they're feeling, what's bothering them, and that patient goes out and does that continuously, or in many cases does that in therapy. I can say to them, believe it or not, shut up. Don't talk. You can imagine, I mean, since there is some sharing of personal answers, you can imagine that Dr. Sobey said similar things to me. His two primary admonitions to me were to shut up and stop chewing gum. I don't know what he would make of the use of the BlackBerry at this point, considering those of us who knew him know he was mechanically phobic. David Silver can well remember our first attempts with Dr. Sobey getting him an answering machine and getting calls like, I don't understand. I pushed a button and nothing's happening. So the point being that what you want to do in treatment in any situation, and I suspect that this is true also in psychoanalysis or other psychodynamic therapies, is you want the energy to be concentrated in the session, in the interpersonal interaction, in the clinical interaction, and anything that pushes off to the side or out and around takes it away from that concentration. But specifically in terms of the kind of work that we're doing when we do in Orgone practice, since you're using energy in a very literal sense to push through and to resolve or to, in a sense, break through a block or blocks, right? You need to have that energy available, and the more it's dissipated by any kind of behavior, including behaviors outside the therapy, right? Outside the immediate therapeutic situation, it diminishes the ability to bring that to bear at the moment when you're doing work. So the admonition in this context is clearly designed to increase the available energy. And that can be significant, particularly if you're dealing with patients who have really very, very problematic charge. I mean, where the energy is very, very dissipated, and where they come into a session and they're very, very flat, either in flat affect or just very depressed, or or in some cases where you get patients who are so highly anxious, right, that you can't even really get them focused, and you can't get them to even begin to breathe or begin to feel their bodies or deal with what they're feeling at the moment. So all of this would really have a very central role, and so it's not simply, as some patients, which would tell you characterologically something about them too, feel that it's that we want to hide what we do because there's somehow some devious, process that's being hidden. And it's not that at all. It's simply that you do not want to deflect from the active concentration on moving and working with the energy as it becomes available. So my case my problem with case presentations from the perspective of treatment is that never accurate or real. That it's never really accurate or real, and that was the other comment I wanted to make. But more in the sense that as I give you a description and Dr. Schiff is going to do a description of a case. It's going to be you'll see some aspects of how you work with a patient. You can do case presentations. It doesn't have to be an orgonomy. You can do a case presentation in any kind of psychotherapeutic modality, just as you can do a case presentation in cardiology, right? Or brain function. The problem is it's always very skewed, and it's selected, and it's presented in particular ways that don't really give you a feeling for what the therapy or the treatment really is. So it's useful as a set of references, as a sense of how it works. But the reality is, for most people who then become therapists, and I would argue probably for most of us as we become patients, it never really quite seems that way or is that way when you're actually in treatment. Right? And the other problem related to that is that to give a case example is problematic in terms of telling you anything about what treatment really is, because no treatment is the same. Probably no treatment is the same in terms of one's own treatment. In other words, in my experience of years of being in treatment with Dr. Sobey, the process changed sometimes weekly, sometimes sometimes it would be fairly level for a while and then go into another level of mode, or as treatment progressed over a longer period of time. Certainly a early period of treatment is considerably different than a long-term treatment, or a patient of mine who comes back in after a successful treatment, or what we would consider a successful course of treatment, calls me up 2 years later and says, I have issues, I need to come in, I want to work. That's going to be a very, very different experience than someone who has had no experience, is coming for the first time saying, I'm feeling very anxious, how are you going to help me? Or what can you do for me? Okay? But more specifically, from patient to patient, while the techniques that we use bear functional relationship to each other, each treatment becomes its own animal in a sense, and it will have, while the dynamics that we've been talking about in the morning remain operative and true, the actual treatment is going to look different if it's with a particular patient in a particular situation, and it can be influenced by many things. I mean, one of the things that I think Dr. Schiff and I have talked about this occasionally, for instance. And patients have done this. I've had patients say to me, I don't want to see you at 5 o'clock in the afternoon, because by 5 o'clock in the afternoon I know you're tired, and I can't deal with you when you're tired. I've had other patients say, no, I prefer you when you're tired. I mean, there are a variety of possibilities. But the reality is, the more significant than joking about it is that when and how the therapy is situated, right, will have a great deal to do with what the course of that treatment is. And also, you could treat two patients who have essentially the same diagnostic presentation, and certainly I think some of the remarks made earlier today also bear on this. So you could have two, let's assume they're phallic narcissistic character structures with a great deal of very heavy body armoring, a great deal of who can actually present quite differently because of their histories and the way they've organized that. So that the assumption that you're going to see the same, that when a phallic narcissist walks into your office, a phallic narcissistic character, that you're going to see the same character that looks just like the other phallic narcissist that you've treated, and that the armoring will be identical, is a mistake. And one of the problems, for instance, in Baker's Man in the Trap as a text is exactly that, which is that it's, and I know from their having contact with some of their training groups, the tendency is to say, you see this, then you do this, and then you do this, and then you do this. It's a very mechanical kind of reaction. Reich was incredibly opposed to that type of approach, right? What Reich would say, and I think emerged from the discussion this morning, is that what you want to get is a sense of really contact with the patient in terms of how they characteristically behave, how they characteristically present themselves physically, and then decide where you're going to intervene and when and how, rather than assume that, oh well, this guy's a phallic narcissist, so I need to do this, and he has an eye block, and I need to do this. Even something as you hear in our discussions or in the literature, someone has an eye block. Well, what's an eye block? An eye block can present in probably, I mean, I could casually think of at least 10 or 20 different ways an eye block can present, and on top of that, that of those 10 or 20 ways, those are probably only the 10 or 20 ways that I happen to have encountered or someone else has pointed out to me. I anecdotally, for instance, worked with a patient, since I'm giving vignettes, okay? It's no one present in the room, so don't worry. I made sure that none of my vignettes involved anyone except me and patients who are unidentifiable, okay? But a classic vignette, and some of you have heard this story because I've told it before. I'm working with a patient, right? And the patient respiration seems clear. From the top down, I've done everything. I've worked on the eyes. Everything seems to be going, and the respiration seems to be full. The pelvis seems to become lively with respiration, but there's no effect in their lives, right? And there's no active change in their external world, outside world behavior. And I'm trying to figure out, and something's not happening. Patient is pleased enough with the sessions, but basically complains that nothing much is happening, and it's very clear nothing much is happening, right? And so I go in and speak to Dr. Sobey, and we're talking, and he says, well, have you looked at his feet? So I said, well, I mean, his feet are flat. I keep him flat on the couch, So well, just look closely at what he does with his lower limbs and his feet. And I observed, and I noticed that his toes tended to curl, particularly his left toe tended to curl, the small toe tended to curl in and hold on to the bed. And I told this to Dr. Sobey. He said, well, so next time you go in there, and while he's breathing very comfortably, just grab his left toe. Right? And I looked at him. Really? All right. So and all hell broke loose. Okay. And and all of a sudden, all of the great progress I had made of seeing this wonderful free movement was very fraudulent, because in fact he was now extremely armored, very tight. His abdomen became tight, right? And what I had missed was that and when I said to the doctor, I was, how did you know that? He said, I didn't know that. He said, you told me that you were looking all over, you couldn't see anything. I said, look someplace where you wouldn't ordinarily look, okay? And the point being that what was happening here was as long as this individual could keep his toes, curled and holding on, even though it was very imperceptible, right? He could let everything else go. Now, I would never in a million years have thought that anyone would use such a minor kind of adjustment, but it can happen. And while this is extreme, and it's not typical, what I would say, it is typical in the sense that we all, every one of us, not just not just my patients, but all of us have our ways, characteristics, and that's what we're talking about here, of protecting ourselves. Most of the time, and often these ways are fairly consistent and predictable, and we can generalize about them. And one of the things I think that Reich radicalized in terms of this whole approach, and as Dr. Weitzman was pointing out in terms of changing even psychoanalysis, was to begin to standardize this and say, no, there really are very standard ways we can understand what is happening. Despite that, that for every one of us, there is an adjustment or a response that can be trickier than any of us could imagine. And that unless you're really attentive, right, you're going to miss it. So that you can work with a patient and figure you've gotten everything and realize, geez, I missed something. And sometimes, if you've done the work correctly, and followed it correctly, when you find where you've missed, you can, with the patient's cooperation, get back to it and proceed. With this patient, it then precipitated a whole new phase of therapy, which actually which revealed to me, very distressingly, that we were actually far less further along than I had assumed. That in fact, that my sense of that nothing was happening was that, in fact, nothing much had happened yet. And so that by simply getting to that moment of that breakthrough was to bring me back to the point that that I should have been, where I should have been from the beginning, was at the top. That in fact he was armored all the way up to pretty much his eyes, but as long as he could hang on by his pinky toe, right, he could let his eyes, look comfortable and look relaxed. Okay, so this again about this idea of the segmental armoring and working from the top down. That's true, but you need to understand it in the functional context of the fact that the patient doesn't come in and say, "Oh, we're going to work." Or some of them do, some patients do because they've read Reich, and we're going to work from the top down. I'm ready to start. So you'll get a patient who will say, "Well, how come you're not working on my eyes? You're supposed to start in the eyes." And I'll say, "Well, or you can get some patients who are even bossy and say that I'll tell you where you have to work." And so you need to then really address what these things present and what each patient presents as they come into you individually. So that one of the things that Reich always said was that you're not going to be able to assume that because similarly, so this technique of getting the toe and triggering this dramatic response doesn't mean that the next time I see someone curling their toes that's going to be where it is and is going to be the answer. And the problem in getting into it in that kind of rigid approach or a mechanical approach is that you get trapped and you get stuck, and therefore the patient will get trapped and get stuck. Anecdotally, again, the interesting story that Dr. Sobey would always tell is that you couldn't, the way Dr. Reich worked. For instance, there's a famous anecdote that he would always love to tell. Some of you might have heard it. He came to Dr. Reich's, there are two great anecdotes, since these are vignettes, okay? And I was told I could say it anyway I want. One was during a huge snow blizzard back in the late 40s, early 50s, no, late 40s. Dr. Sobey was in residence in New Jersey, came across from New Jersey in a blizzard, right, with the flu. Really sick after doing a 72-hour shift on call. Traveled into Manhattan and then out to Great Neck, in a blizzard, right, and gets to Dr. Reich on time. Dr. Reich takes one look at him and says, "What are you doing here?" And Dr. Sobey says, Well, I don't understand. I had an appointment. He said, but you're very sick. What are you, crazy? What, you should be home in bed. And the point being that was therapy. And for Reich, what he had done is he made a very clear point to his patient that he was acting irrationally. And that a rational organism would have realized that, he should have been staying home in bed rather than get,
He never should have gone to Great Neck since Red was in Forest Hills.
Forest Hills, I'm sorry.
Part of his trip.
That was part of his, he was delusional. Forest Hills, right. So, Forest Hills, Great Neck, what's the difference? About $10,000 in real estate value at the time. Okay. So, to then give some examples, of the variety of kinds of cases that you can see in terms of this treatment, and to answer along with that, I realize answering some of the questions that often are posited. We see patients. I have patients who have been in treatment in one way or another with me or other therapists for over 40 years. There are a couple of patients of mine who were seen by Dr. Reich, and that's many, many years. Okay, so one would ask the question, and there's an essay, there's a famous essay about therapy terminal, and terminal, and how long therapy should go on, and in many cases. We hear, and it's discussed that Reich, and maybe some of the archival material will make this clearer, that Reich was fairly clear that he would usually treat a patient for 20 sessions, and if he was known to have said that if I can't, effect a cure in 20 sessions, I terminate treatment, and that has often been mistakenly interpreted when I discussed this with a number of people who have worked with Reich to mean that if he couldn't effect a cure, that no treatment was possible. What it really meant was that he was no longer interested at that point in continuing to be the primary therapist. He would usually refer the patient to one of the other therapists for long-term treatment. That he himself did not oppose long-term treatment, right, or did not reject the idea that some patients might be in treatment for their whole life in some way, but that he himself was not interested in carrying out that kind of treatment.
Did he achieve some cures in that short?
Well, supposedly, and to speak to people, I mean, again, what constitutes a cure? If a patient says, they're feeling better and doing better, and they're alive. Yeah, no. I mean, actively, and according to what we know historically, he was renowned as a great therapist. That people who went to see him felt that they were helped, substantially and considerably. But that didn't mean that some of those patients didn't wind up back in therapy again, or seeing other therapists who worked with Dr. Reich. I see a woman who was seen by Dr. Reich, who was then off and on in therapy, has been off and on in therapy for the remainder of her life. She was very young. She was probably in her teens, and then continued with various therapists, but primarily with Dr. Sobey, and then with me, for now going on probably close to 60 years, if not more. And she would be the first to tell you that the only thing that's kept her alive this long and has kept her as productive as she is has been therapy. And treatment, and she never was hospitalized, right? And she would openly, since if she were here, she'd be first to tell you that classically would be diagnosed as paranoid schizophrenic, highly, but has remained within the limits of her life, highly functional, highly productive, highly engaged, and by standards of standard treatment, this is a successful treatment, and without medication. She's never been on psychiatric medication. Is she? If you encountered her, would you say that she's the picture of health? She's eccentric. She's difficult. She's She's many things, but she's quite lively, she's quite engaging, she's quite productive, and when she's in a good mood, she's quite delightful. When she's in a bad mood, she's impossible. But again, what we have to then question health. But what she is energetically quite alive, capable of sustaining a great deal of pulsation in her organism, as most schizophrenics are to some extent. The problem being what happens when the pulsation begins to become pronounced. What clearly orgonomy did for this patient was give her means and ability to tolerate these pulsations and organize the experience of her pulsations in ways that were productive rather than basically it allowed her therapist to help her develop some functional armoring, some ability to stay contained, to stay intact when faced with a buildup of energy that she couldn't that would be ordinarily intolerable. Okay. On the other side of the spectrum, a woman comes in who is in a panic, right? Because she has been identified as a lesbian in her own life for many years, is part of an active, extended lesbian community, is a key player on a softball team, and anyone who's been involved with the lesbian community knows that softball was a very big sport among a lot of lesbian groups. She's very identified with this, and in a panic because she's begun to have very strong genital feelings towards men. She's feeling very strongly a desire to be with men, and is mostly panicked, not so much about the feelings, but that she's pretty much resolved before she's come in that she wants to start being with men. Matter of fact, she started exploring the possibility of being with men. She's begun to get involved with a man. But she's in a panic because this means that she's going to probably have to drop off the softball team, literally. Really move away from the life that she's deeply invested in, and professionally also had connections, networks. This was going to be very disruptive. Treatment progressed for 6 months and was very successful. And basically, it was in some ways an easy treatment because she was quite alive and quite ready and becoming very genital before I ever got to see her. It turns out she was pretty healthy, right? After working with her, it was very clear she was pretty healthy. Most of what treatment involved was helping her, and supporting her, not so much in a physical treatment, had a lot to do with social work and just sort of what we would call supportive therapy, just saying it's okay, you can go out with this guy, you can have a relationship, you can move, you can change your dynamic, and she began to establish fuller, healthier life. And in many ways, I would say it was one of my first examples of a patient who came through to a genital reflex and began to have a really active love life, and got married and had a kid, and lived happily ever after. Not quite, but was very active, right? In terms of changing her life, and most of what the therapy involved was managing her transition into a new kind of experience and a new way of organizing her life and dealing with the anxiety of these changes. And the other thing, physically, which I it's too bad I don't use photographs. It's the most astounding thing. This is a woman who has, when she presents, and she insists that this is a genetic characteristic in her family, that all the women in her family have almost no chin. When she breathes and begins to become very alive, her chin comes out. At the end of sessions, I would have her look in the mirror and she would have a fully pronounced chin. And she said, that's not possible. My mother doesn't have a chin. How is that possible? And I said, get your mother to breathe. She said, that's not possible. So I was told that I had 5 minutes about 2 minutes ago. On the other hand, I'm reminded of to go to the other extreme, a patient who is severely restricted, right? Who came in having gone through some really traumatic, abuse counseling for sexual abuse with recovered memories. It was during the period of time when they were doing this whole, what was it called, early recovered, recovering memories, and she had been convinced through a therapist that she had worked with out in the Midwest that her parents had literally been sexually abusing her, and her brothers had been abusing her, and she had a huge fantasy life of, or as far as she was going to clear, she had cut off from her family and stuff, and could not tolerate, and so most of the therapy was one to support her in the fact that she clearly felt that these things had happened to her, right? But on the other hand, this was not a patient that I could put on the couch. Or the attempts at getting her on the couch and getting her to breathe were very, very limited. And the sensations that she experienced when she began to breathe was so overwhelming and created such anxiety that alone was almost impossible to manage. But what was interesting is she became increasingly dependent on me. So that this didn't scare her to leave therapy, but she became increasingly dependent on therapy, but became less and less functional in her life. The more we got into this, and her anxiety levels became increasingly unmanageable, and eventually we had to work in collaboration with a psychiatrist, to medicate and help maintain her. So again, you need to also look at patients as not some sort of continuum of here's the patient, they have this problem, you go this way, and then suddenly you get to the genital reflex. They go, and then to end on the point that even if we're successful, for instance, with this woman I described who did very, very well, the relationship that she was in that seemed to be so perfect turned out to be far from perfect, and she came back into treatment for a while because her husband the relationship became problematic. She went into a panic, and there were all sorts of issues, and there was potential for abuse, and she needed a lot of help getting through that, but she got through it. So again, therapy can serve, and even orgonomy can serve many purposes. And Dr. Sobey was always pointing out that, not to think of orgonomy as medical orgonomy versus social work, because a lot of times we as therapists, whether we're psychiatrists or psychologists or psychiatric social workers or what have you, are also going to have to work as social workers. In terms of helping or job counselors in some cases. It can be many, many things that influence the way we engage the energy and help it move and help the patient basically help the patient deal with the impact of going back into what we talked about earlier, the compulsive world that we all live in, and even if treatment is successful. Okay, and I'll finish just quickly by saying, coming back to the final point of saying the last anecdote, which is when Dr. Sobey told, again, Dr. Riker said that you're not to talk about your therapy, that all the therapists took that very seriously. And when Dr. Reich was dead, about 6 months or maybe within the first year of his death, they had regular meetings, and finally at one of the regular meetings, everybody sort of broke down after the meeting and started talking about their therapies, right? And their experience of Dr. Reich. And Dr. Sobey said it was the most bizarre experience in his life. He said, first of all, not one of them could describe Dr. Reich in the same way. Some of them described Dr. Reich as being over 6 foot tall, which he wasn't. Others described him as being almost a midget, really tiny. Others described him as being heavy. Others described him as being thin. But what they all consistently described as they talked about is that not one of them had the same therapy. But all of them were in orgone treatment with Dr. Reich. And why was it different? The difference was that Dr. Reich wasn't interested in whether he was doing orgone therapy as much as whether he was working with that patient to achieve the goals of orgone therapy. I guess that is that a presentation about orgone therapy and with vignettes? I don't know. Thank you very much. to take questions?
No,
Oh,
no,
no,
you're
no.
fulfilled.
Oh, I see.
You did it.
I don't have any.
Okay, Dr. Schiff's.
I have no
next.
questions.